Hello, Partnering for Vaccine Equity, learning community members, and others working to advance vaccine equity. I am Bridget Courteau. I'm the Director of Group Learning for the learning community. And on behalf of our team at the Urban Institute and our partners at the CDC, thanks for being with us this afternoon. Our country's response to COVID-19 has changed over time, and those of you working to advance vaccine equity in your communities have adapted to these changes. You've made sure that your approach to outreach and vaccine access evolved to reflect new policies and programs. A key new program to extend access to COVID vaccines for adults is the Bridge Access Program, which focuses on the uninsured and underinsured populations. Our PAVE partners and others working in this space might have questions about these populations, how to engage them, and how the Bridge Access Program works. And so this learning session will address all of these topics. Before we go any further, I'm going to review a few key points about how this session will work. First, we do offer live interpretation from English to Spanish during our events. If you would like to listen to the Spanish channel, simply click on the globe icon that's on the bottom of your Zoom taskbar and switch to the Spanish language channel. You've all been muted upon entry to the session. If you have a question for the speakers during the presentations, please put them into the Q&A tab. That's also at the bottom of your screen. And we're planning to have dedicated time for questions and answers at the end, but we also have a tight agenda. So I encourage you to ask your questions as they come up, since the speakers might be able to answer them in the Q&A tab or work them into their remarks. The chat is also open and we'll be monitoring it. We encourage you to use it to introduce yourself or to comment on what you're hearing, but please don't put questions for the speakers there because we don't want to miss them. We would really like you to use the Q&A tab instead. After this session, we will share the recordings and the slides with the PAVE learning community and through the Adult Vax listserv that CDC manages. And finally, just a heads up that as we approach the end of our session and transition into Q&A, we will be launching a very brief poll of your satisfaction with this learning event. We really appreciate your feedback, and we hope that you'll participate in this poll when it pops up. And of course, if you have technical difficulties at any point during the session, send an email to our community manager's inbox. That's vaxequitylearning@urban.org. It's also here on the screen because we want to know about these so we can help you troubleshoot and avoid similar issues in the future. Next slide, please. So it's my pleasure to introduce our featured speakers for today. First, we're going to hear from Jenny Haley. Jenny's a principal research associate and a colleague of mine in the Urban Institute's Health Policy Center. And in addition to being a member of our group learning team for PAVE, Jenny conducts research on maternal, child, and parental health and healthcare, Medicaid and the Children's Health Insurance Program, and health equity. Jenny holds an MA in sociology from Temple University. After Jenny, we're going to hear from Sarah Price, who's the Director of Public Health Integration at the National Association of Community Health Centers, or NAC. Sarah provides technical assistance for the integration of public health initiatives, including adult immunizations, pediatric weight management, and other emerging topics. Sarah serves as an adjunct faculty for public health nursing at Georgetown School of Nursing, where she guides nursing students through their public health nursing rotations. With 22 years of experience in community and public health, Sarah specialized in the strategies related to interdisciplinary care services and innovative primary care workflows. She earned a Master of Science in Nursing Education from George Mason University. And our third and final speaker will be Dr. Caroline Day, who is Chief Medical Officer at Family Care Health Centers in St. Louis, Missouri. Dr. Day has served as a family medicine physician at Family Care Health Centers since 2007, and she's honored to take part in the Community Health Center mission focused on the uninsured and underinsured patients in the context of families. She trained at University of Colorado Boulder as a chemical engineer, but her passion shifted to people and improving our healthcare systems. She completed training at Washington University School of Medicine and family practice residency at University of Wisconsin-Madison. She also completed the Northern California Faculty Development, studying leadership skills for the physician in promoting positive change in healthcare and skills for providers to avoid burnout. And finally, Dr. Day completed a fellowship in underserved care at University of California, San Diego, as well as a master's in public health at San Diego State University, focusing on the meaning and the means for quality in healthcare and shared decision-making between patients and their providers. Before we get to our main event, we have a brief announcement from our partners at the Association of Immunization Managers. Ellie Austin has joined us for this. And so Ellie, I'm going to turn it over to you.
Thank you so much, Bridget. As Bridget said, my name is Ellie Austin, and I am the Member Services Coordinator for the Senior Member Services Coordinator for the Association of Immunization Managers. I am a Black woman wearing yellow glasses and a green turtleneck sweater, as well as white headphones. Next slide, please. So just a little bit of information about the Immunization Champion Award. This is a really great opportunity for our partners in the immunization community to recognize an individual who in their community goes above and beyond to promote or foster adult and childhood immunizations in their communities. So AIM works with the CDC to create this award, and so we are very excited to have had 41 awardees recognized last year. We definitely want to increase that number. And so AIM is coming to our partners to share information about this award to increase participation and increase awareness. Next slide, please. So we just want to highlight a few of our champions from last year. All of these champions were from jurisdictions who had not previously participated in the year before. And so we're really excited to see these new faces in the award program. Next slide, please. So just some information about how the process works. What we have available on our webpage, which I'll put the website in the chat as well too, but just so you can kind of know the process, we'll accept nominations on our website. However, also jurisdictions might put out a call for nominations as well, and you can submit directly to them. AIM will send the nominations at the end of the nomination period to their jurisdiction so that they have time to select a champion. And then they will send us that information so we can send out an award plaque and a congratulatory letter to awardees. And then champions will be featured on our website as well as on the CDC website during National Immunization Awareness Month, which is in August. Next slide, please. So healthcare professionals tend to dominate in the champion arena, but we also want to make sure people know that there are other opportunities that this is an opportunity for a lot of us in the community. So this can include nonprofit leaders, community activists, parents, school and education leaders, and any other immunization partners that you work with or know of. Just a few notes about who is ineligible. Immunization program managers are not eligible for this award. They'll be the ones selecting the champion. And then county, state, and federal government employees paid by state or federal immunization funding, individuals who are employed or affiliated with any pharmaceutical companies, as well as individuals who have already received the award. So on our webpage, you'll be able to see the awardees from 2022 as well as 2023 to double check to make sure that someone has not received the award before. And again, this is an award only for individuals. So if this describes you or someone you know, then we want to make sure you have an opportunity to nominate them. Next slide, please. So just a bit of information about just, again, how our timeline works. The nomination period on our website opens today and is going to be available until May 10th. And then again, at the end of the nomination period, we're going to submit to our jurisdictions the nominations we've received on their behalf. And then the jurisdictions will select a champion by June 28th. July, we're going to get all of the award packages together and send them out to awardees. And then in August, we'll feature the champions on our website. Next slide. So again, it was really important for us to be able to have this opportunity to share with you information about the Champion Award. So thank you so much for your time. We want to make sure to share with you our one-pager so that you can share that with your networks, and that will help us to encourage nominations. Any information you can share about the award program at newsletters and webinars is definitely helpful. And then also we want to hear feedback about how AIM can continue to improve the program. So what I will do in the chat is add our one-pager so that you can download that and share that with your networks. I'll add the link to the nomination form so you can go to our webpage and either nominate yourself or someone you know. And then we'll also add the email address for any questions or concerns that you have or any feedback that you have as well too. So I'm going to go ahead and pass it back to Bridget. Thank you so much.
Thank you, Ellie. This is the perfect crowd. I know we have a lot of immunization champions in this group and in the PAVE community. So I really hope some folks in the audience think about nominating someone that you work with or that you think fits this description. So thanks again, Ellie. And let's go right into our presentations for today. So I'm going to hand things over to my wonderful colleague, Jenny. Take it away.
Thanks, Bridget. So my name is Jenny Haley. As Bridget said, I'm a white woman with dark brown hair, wearing a purple top and a headset, and so glad to be with you all today. Next slide, please. This is just an overview of what I'll be discussing. I'm going to start with just some key terms about health insurance, a general overview, and then talk specifically about insurance coverage for adult vaccinations, followed by a brief profile of the uninsured population, and then some resources for supporting uninsured and underinsured adults who don't have no-cost vaccine coverage in obtaining immunizations. Next slide, please. Actually, two more. So I'd like to just jump in with a really broad overview of health insurance coverage in the United States. Generally, we can classify people into three broad groups. The first is public coverage, and that's coverage provided by federal or state governments. Primarily, that is Medicaid, which is coverage for low-income people, some pregnant people, or people with disabilities, and some seniors. And then Medicare, which is coverage for people who are 65 or older, or some younger people with disabilities. And both of those can be delivered through a managed care plan. So sometimes people don't even know which type of coverage it is because they just know the company that they're enrolled in. But that doesn't mean that it's not a public plan. And then finally, military coverage. So the second group is private coverage, which is that coverage that's purchased by consumers on behalf of consumers by someone like an employer. And the main types there are employer-sponsored insurance and non-group coverage, which can include what might be called Obamacare or exchange or marketplace coverage. And then the third group is people without any coverage at all, the uninsured. Next slide, please. I wanted to give you a sense of how people are distributed in general. And so this is a pie chart that uses 2019 data from a survey called the American Community Survey to show the distribution of coverage for people of all ages. This includes children, elderly adults, and non-elderly adults. So what you can see here is that about half of all people in the US in 2019 had employer-sponsored insurance. The next largest group is Medicaid, and because we're talking including kids in this figure, that includes the Children's Health Insurance Program. Those groups together are about 1 in 5 people. Then about 14% of all individuals have Medicare, about 6% have non-group coverage, and fewer than 2% have military coverage. So the rest, about 9% in 2019, were uninsured. And so that group is the main focus of the webinar today, though as I'll get into a little bit later, some people in some of the other groups may also lack coverage for COVID-19 vaccines. And that would bring up the importance of the Bridge Access Program for them. So the next two slides briefly go through some terms that can come up when discussing health insurance. There's providers, of course. Benefits are what the plan pays for in the network of providers that the plan covers. One thing to note is the difference between providers who are in or outside of a plan's network. Using an out-of-network provider can be more expensive. So in thinking about coverage for vaccines, it's important to know which providers are in a plan's network rather than outside of it. And we can talk a little bit more about that later. The next slide has a few more terms. I did want to note that generally there are certain benefits and services that plans have to cover, but some of the people who may be eligible for the Bridge Access Program might have more limited plans that don't meet those requirements. And then I just wanted to quickly note a few terms related to costs. Premium is the price that is paid to the insurer for the coverage, but then a co-payment or co-insurance is the share of costs that an enrollee pays for covered benefits. So when we talk about having a copay for a vaccine, that would mean what's the amount that the person might have to pay to access that benefit. Next slide, please. So now I'd like to talk specifically about coverage for adult vaccinations. And the next slide includes some requirements, noting that most public and private plans must cover vaccines without cost sharing for immunizations that are recommended by the CDC. And that includes COVID-19, influenza, and other adult immunizations. Next slide, please. So now I'm going to get into a CDC resource on the Bridge Access Program that helps us understand a little better who might be eligible for the Bridge Access Program. And this slide is from a CDC presentation slide. It's linked in the source here. And then I also will be going into more detail on this image you can see on the right, which is the CDC vaccine. And while I'm talking, I'm going to put that into the chat. Of course, I can never do two things at once, but there we go. So what this fact sheet really goes over is showing that most private health insurance, Medicare, and Medicaid plans cover COVID-19 vaccines without cost sharing. On the other hand, uninsured adults can get a free COVID-19 vaccine through the Bridge Access Program. And adults whose health insurance plan doesn't cover COVID-19 vaccination costs in network can also get a free updated COVID-19 vaccine through the Bridge Access Program. And then separately, it's not a focus of a PAVE, but children 18 and younger who are eligible for the Vaccines for Children program would get their vaccines through that program. So the next 3 slides, I will just walk you through some of the details of this resource from CDC. So the first section discusses private health insurance plans. It notes that most routine vaccinations must be covered by insurance without cost sharing when administered by an in-network provider. And the CDC recommends that people check with their insurance plan to make sure that they are using an in-network provider for that reason. And then if we go to the next slide, I zoom in here on the next part of the fact sheet, which notes that Medicare, Medicare Advantage, that's Medicare that is delivered through a managed care organization, and Medicaid covered COVID-19 vaccines without any cost sharing. Then it talks about how to find out if an insurance plan covers COVID-19 vaccines. So first it says check the insurance plan for details such as through calling or using the plan's website. And then it recommends asking a provider whether they in fact accept that health insurance plan and making sure again that they're in network and asking whether they would charge any out-of-pocket costs for the vaccine. So that is how providers and consumers can work together to understand whether or not someone could be served by the Bridge Access Program. So the next slide really highlights a piece of a fact sheet, which helps us see that the target population for the Bridge Access Program is uninsured or quote underinsured people. So again, those are people who do have insurance, but it does not cover vaccines without cost sharing at an in-network provider. So those are the main populations that we're interested in. Now, next I'm going to go through some data. It focuses on the uninsured population. Unfortunately, I don't have comparable data on the underinsured population. But when you're thinking about how to focus on this population of people who might be eligible for the Bridge Access Program, I thought it would be useful to understand specifically who uninsured people are. Next slide, please. So first, you can see here that the risk of being uninsured varies across different subgroups. So this slide and the next few slides focus only on non-elderly people, because if you can think about most people over 65 who are in the elderly category are served by the Medicare program, and so almost all are insured. And then if we want to drill down to the uninsured population is what we're doing here. And so you can see very quickly in the first two bars that non-elderly adults are more than twice as likely to be uninsured than children. 11.3% are uninsured versus just 5% of kids. Partially that's due to more generous public coverage for children in Medicaid and the Children's Health Insurance Program than for adults. Going over to the next set of bars, you can see that Hispanic and American Indian, Alaska Native individuals, as well as Native Hawaiian or other Pacific Islander individuals, and to a lesser extent, Black individuals, are more likely to be uninsured than those who are white or Asian American. Then to the right, the last set of bars shows variation by state policies according to the Affordable Care Act expansion. I'll go into those a little bit later. So the next slide, really we're going to think about the whole of the uninsured population, understanding the characteristics over the next few slides. So the first one here shows that most uninsured people live in families with one or more workers. Over 70% are in families with one or more full-time workers. The next biggest group, about 11%, in families with part-time workers, and only a little under 16% in 2022 were in families with no workers at all. The next slide shows that uninsured people belong to a variety of income categories. So about 1 in 5 uninsured people is in a family living below the poverty level, and that's about $26,000 a year for a family of 3. Another 1 in 4 are just above the poverty level, and then about a third have family incomes between twice and 4 times poverty. About 1 in 5 has incomes above that level. So really quite a lot of variation in terms of the income groups that people belong to among the uninsured population. And then the next slide shows that the largest uninsured groups are people who are Hispanic or who are white non-Hispanic at about 40% and about 38% respectively. About 13% of uninsured people who are non-elderly of all ages are Black, and then fewer than 5% are in the other racial groups that were possible to see in these data. And not shown here, people who are US citizens are much less likely to be uninsured than those who are not US citizens. So next slide, I want to get into a little bit in variation in uninsurance across states. So nationally in 2022, about 9.6% of non-elderly people were uninsured. But this is a map of US states that shades the states according to their uninsurance rates, with higher uninsurance for the darker areas and lower uninsurance in the states with the lighter blue. And so you can see really a lot of variation from a high in Texas of 18.9% to a low of under 3% in Massachusetts. And you can quickly see some regional patterns like the Northeast and the New England states having pretty low uninsurance rates, and with states in the South having higher rates. And the next slide shows part of the reason for this variation. As of the end of 2023, most states had decided to adopt the Affordable Care Act Medicaid expansion, which extends eligibility for Medicaid to 138% of poverty for non-elderly adults. But 10 states had not adopted that option. And in those states, most adults who are not disabled or pregnant or parents really have no pathway to becoming eligible for Medicaid, regardless of their income. And even among parents, the one group with some broad potential eligibility in those states, it's a very, very low income threshold. So a lot of people don't apply. So you might notice a relationship between this map and the one before that showed uninsurance rates. And if you are working in a state that's one of these non-expansion states, you might find that more adults in your state are uninsured and might be eligible to be served by the Bridge Access Program. Next slide. Just wanted to go into one more note in terms of this coverage landscape is that during the public health emergency, states were required to keep on Medicaid anyone who was enrolled at the start of the pandemic or became enrolled over the next months and years. And they were required to keep them enrolled until about a year ago. But now they are reprocessing application eligibility of all those enrolled people. And a lot of people are losing their Medicaid right now. And this process is called unwinding of the requirement that was in place during the pandemic. And so you might find in your work as you're trying to help understand people's coverage status that you're finding people who are losing Medicaid right now, and they might be becoming uninsured, perhaps newly uninsured for the first time in 3 years or more. This figure here shows one measure of drops in Medicaid enrollment across states. As before, you can see a lot of variation across states. So the risk of people encountering that issue might vary across states, but overall it's a confusing time for people who might have been enrolled in Medicaid before, and they might not understand whether or not they have coverage. So just wanted to make sure you're aware of that. Okay, so just a few more slides from me on supporting uninsured and underinsured adults without no cost coverage. On the next slide, I mentioned 2 resources for finding out about your local uninsured population. There are, I'm sure, others, but just wanted to profile this resource. The Rural Health Information Hub, I think, could be really great because it has a tool that provides the county level share of non-elderly adults who are uninsured. And that might be useful to all of you for understanding where uninsured adults might be in your state to be served by the Bridge Access Program. Another source is, as I mentioned, the quote unwinding going on. Some states have developed what are called unwinding dashboards, where they're tracking how many people are losing Medicaid, what are their characteristics, where might they be located. And so you could also search for that in your state and see what you can find out about the uninsured or the previously Medicaid enrolled and understand how their risks of uninsured might be going up. Next slide, please. Finally, and you will be getting the slides later on, so you can link to these resources. I just wanted to share several resources for communicating with uninsured and underinsured adults about the Bridge Access Program. And some of these are from CDC, and then I also link to a National Urban League radio PSA that specifically is about the Bridge Access Program and trying to reach uninsured people. And so I thought that might be useful for all of you. So that is it for me. I will hand it back to you, Bridget. Thanks.
Thank you so much, Jenny. And so with that sort of primer on the uninsured and the underinsured, we're going to hop over to hear from Sarah Price, who's going to tell us about a really key set of providers for the uninsured and underinsured population. So welcome, Sarah.
Thank you so much. So glad to join you. I've been on many of these calls as a attendee, so it's lovely to have the opportunity to speak. As Bridget and Jenny shared, my name is Sarah Price. I'm a community health nurse of 22 years. I'm currently working at the National Association of Community Health Centers. I am a middle-aged white woman with blonde hair and a very vibrant red shirt on today. And again, I'm so grateful for this opportunity. Next slide, please. So I want to take a little bit of time to actually tee up Dr. Day, who's going to be next, who actually works at a community health center, but just to tell you a little bit about community health centers in general. Community health centers are the largest primary care network in the nation. We always say that we're the best kept secrets when it comes to primary care, but just wanted to give you a little bit of a background on that and then talk a little bit about their role in accessing the Bridge program. So community health centers all are nonprofit. They're all patient governed, meaning that every community health center's board is made up of at least 51% consumers, which is a really unique approach to governance. Each provide high quality and comprehensive healthcare to underserved communities and uninsured and uninsured. And now you know all those definitions, thanks to Jenny. We serve all patients regardless of ability to pay or insurance status. And again, that governance piece is really folks from the community who use those centers. I like actually the next slide, if you'll go to that one, I actually like that visual better. It's easier to see. There are 15,000 brick and mortar delivery sites. I shouldn't even say brick and mortar. We also give shots and do access healthcare in under bridges and in fields and things like that too. So there's really over 15,000 delivery sites. There's count right now, there are 1,487 health centers that exist across America. That's 1 in 11 people served in the US. 31.5 million patients are served by community health centers. And you can kind of see the breakdown of folks. It's 1 in 7 rural. It's 1 in 3 living in poverty. There's 8.8 million children, 400,000 veterans. So again, we really aim to serve those who are either underserved, but we also serve people who are served. We serve private insurance folks too. So that's certainly all comprehensive. Next slide, please. The impact that community health centers have on general comprehensive primary care, of which immunizations, as you can imagine, is a huge aspect. There are 95.5 thousand medical professionals. We have dental health professionals, behavioral health enabling services, with a growing network of actually 100,000 total employees. Lots and lots and lots, with a total of 127 million total patient visits, and climbing as Jenny was sharing about Medicaid unwinding and all of those. You know, our population fluctuates, and again, we are the safety net. So for folks who either have Medicaid, don't have any insurance, have commercial insurance, we serve everybody. We serve them all. So you can see just how large this network of community health centers is. Next slide, please. When I say community health center, I want to be clear of what we're talking about. So community health centers, again, I said there's about 15,000 sites. This slide's 14,327. There's almost 4,300 healthcare for the homeless centers. There's almost 3,000 migrant health centers, primary care programs and public housing, and also school-based health centers. And each of these entities, if you recall, they're an independent 501c3 nonprofit. So we act as a network, but each is really their own nonprofits and governed. And NAC, who I work with, the National Association of Community Health Centers, is really the advocacy body. We sits with research and analysis, training, leadership, networking, convening, support, all of those things for each of these community health centers, whether they are our members or not. So if you think again, you know, thinking of community health centers as this humongous primary care network that's, again, acts in each community independently, but is part of a larger network. So just wanted to really bring that home as a key message today of how large this network really was. Next slide. We also work alongside primary care associations and health center controlled networks. Many of you who've maybe worked in the immunization space or work, you know, as a jurisdiction may be more familiar with primary care associations. There's one in every single, or at least one in every single state or jurisdiction. And they are federal grantees. They have really strong ties to Medicaid departments, state health departments, governor's offices, legislative, and they help to keep the federal grant for community health centers kind of alive and well. And they also do a lot of work to convene services across each state. Health center control networks is actually networks of health centers. So they cross state lines. They work a lot in IT, billing, clinical quality, et cetera. So a state may be part of a community health center may be part of a state PCA, but they also might be part of a network as well. So there's just two extra kind of support systems that add to our large network piece. And I'll talk a little bit about how those two entities, HCCNs and primary care associations, really helped with the Bridge Access Program in a second. Next slide. NAC and community health centers also partner with all sorts of different folks. So if any of you sit in any of these spaces, in academia and accreditation, other associations, federal agencies, NTAPs, we partner with everybody on that. We know that it takes a village to serve the underserved. And so we are always looking to partner with entities, and whether that's an official partnership that crosses resources or money, or whether that's memorandum of understanding, or whether that's just a handshake working in the same field. We do it all, and we really believe in strong partnerships and being both a provider of choice and choosing partners who were on board with us as well. So just wanted to shout out to our partners there. Next slide. And then I kind of alluded to this, but this is the current health center workforce. So each of these, I can actually name either an individual or some kind of scenario in which each single member of our current health center workforce in all of these different roles was able to successfully contribute to increasing access to vaccinations, especially during COVID, but continuing through all vaccinations as well. So each of these play a part in vaccination and in primary care. Each of these different entities really outreach to serve that 31.5 million patients that community health centers do. So it takes a village, it certainly does. Next slide. So just a key thing, I know I'm standing between you and Dr. Day, who actually has a real story on the ground, but just wanted to talk about NAC's role in helping health centers to access the Bridge Access Program. So CDC announced the Bridge Access Program. We have really strong ties with CDC. So, we knew it was happening. It wasn't a surprise to NAC. And then what we were able to do is actually provide and distill some of the guidance. The guidance that came out was really robust and really rich. What we did is we then took out some really, really important key pieces, and we're able to message that directly to our health centers to say, hey, don't miss this paragraph. Hey, this piece is really, really important, and then post that on our website for health centers. We were able to also talk with our immunization programs, our PCAs, and health centers, just like Dr. Day's, to address any questions or barriers, and also successes around the Bridge program. And we're able to funnel that back to CDC or to the PCA or the network in any way that we wanted. And that feedback actually led to some really great tailored approaches on vaccinations, and then also partnerships between CHCs, PCAs, immunization programs, and CDC. So we really saw ourselves as some of the bridge builders to the Bridge program, and with community health centers really being that key piece. So my last slide, and then I'll turn it over to Dr. Day. Just wanted to thank the Bridge Access funding people who decide who gets those, because the total awards was $81 million worth of support to 1463 health centers. Again, we have 1487, so that's a pretty good rate of funding towards health centers. So I want to stop here and turn it back to Bridget, and then let Dr. Day tell her story from the community health center level. And I will put a link in the chat of our adult immunization page to the NAC website if you want to learn more or connect with me. Thank you.
Thank you so much, Sarah, for that overview. And I will, without further ado, I'm going to hand it over to Dr. Day. But I do want to remind you that, especially since we don't have a ton of time for Q&A, if you do have a question, please put it in the tab so that we can see it ahead of time and get them ready for Q&A. Dr. Day, the floor is yours. Thank you for joining us today.
Yes, thank you. So I'm thrilled to be here. This Bridge Access program really helped us to continue what we had started, and I'll give a brief overview of that. I want to give credit to, I have a couple motivational interviewing slides that are created by Dr. Kelly Gable and Julie Blanco, who started us trying to get our patients vaccinated in 22. So next slide. Just to introduce myself, I'm a about 50-year-old white woman. I'm wearing a black shirt and a headset, and I'm thrilled to be here and just talk about what were our steps in getting to us where we are now. I am in St. Louis, Missouri, and I'm at an FQHC, or federally qualified health center, that serves about 200,000 patients. We have a wide spectrum of patients and serve primarily about 6 different languages, but up to 20. So we have a wide variety of patients who are coming to us, and we started to learn about motivational interviewing when we first acquired the COVID vaccination to be able to give to our patients. We started trying to figure out how to entice patients to get the vaccination if they were unsure. And so my slides go over that process of trying to build confidence, meeting our patients at their appointment, and the bridge funds really allowed us to do that for any patient and not have a different program depending on which patient's in front of us. And then I want to talk about the resources that we tapped into for our community neighbors that helped us with their assets of building best trust with our community. And then finally, our takeaway of when you get the vaccination, patients will get it when they're ready and have access. Next slide. So really the power of communication, we anchored in this motivational interviewing, because I think the luxury, as you kind of learned in the previous presentations, is having relationships with our patients. And our patients have lots going on in their lives. They often are working, sometimes 2 and 3 jobs. And so coming to our office is tricky, and they will come if they have a relationship and they know what they can get in their visits. Next slide. I think in healthcare in general, we are helping professionals and we want to direct people to how they should improve their care. Obviously, that's our mission, that's our passion, but we have a risk of overwhelming in our desire to persuade patients to do the right thing. So again, I'm just going to briefly touch on motivational interviewing because it's obviously something that many of us have already heard about, but I just feel like if that comes before the bridge access, we have a much better chance of really helping our patients get what they want. By doing our writing reflex of trying to push things, patients are going to feel uncomfortable, defensive, powerless in their care, and maybe resistant to what we're offering. Next slide. And obviously we want to build trust. And if we aren't building trust, then we're actually going to push people to not utilizing the medical system because they don't feel like they are comfortable with us. And they may not then get the preventive care and treatments to keep them healthy. And obviously, many of you are aware that there are things that have happened that have kind of seeded this distrust. And there are many examples that you can see on the slide. Obviously, the lack of diversity in healthcare can sometimes be a barrier, as well as language barriers, poor communication, and just personal experience that may be challenging. Next slide. So really in our efforts building up to having the vaccine available and getting it more frequently and for more people, we really focused on these 5 areas. 1, acknowledging and validating our patients, you know, the fact that they have distrust, the fact that we need to work to build that trust, opening the door to discussions, really listening to where they're coming from and what their ambivalence or hesitation is, and always keeping patient autonomy first. Next slide. So many of you know about motivational interviewing, but this acronym has really helped us as healthcare workers that need to continue to grow and be best available to our patients. It's the acronym of PACE. P, focusing on the partnership, really having, when patients come to us, being a collaboration, that we're working on things together. Acceptance, really supporting their autonomy and choice. And I think the beauty is that if you do this at each and every visit, The choice can change as they feel more confident. C is a compassion, really to understand the sense of where the client or patient is coming from, what their personal meaning around all these different health offerings are, and how to help them work through that process of understanding what they need and why. And then finally, using invocation to really help them process out loud. How's this pandemic affecting them? What do they think that they can do to get the most of their personal health in these circumstances? Next slide. So I won't show a video here. This again are slides that I borrowed from Dr. Gable, but really these are the things that we've brought to each and every visit. And I want to pause here to just say, this is training that we not only gave to our medical providers like our nurse practitioners and physicians, but we also gave to our medical assistants. We also gave to our operations front desk people and our dentists and our pharmacists, so that everyone was primed and ready to help start the conversation by asking what information the patient needed, to offer new information if they were asking for it with their permission, and then to ask again, what are your thoughts about getting vaccinated? And so it's really this opening a door, but not pushing somebody into it. Next slide. So I would say that at a community health center, we know a lot and we offer and build relationships that help us know our patients, but we really leaned on community partners who have resources, particularly during the pandemic, that help build that trust, that they really helped us to understand where some of the distrust is coming from, what people need, helped us build confidence building strategies by leaning into their sensitive resources. And luckily at our center, we have 11 community health workers who, in my mind, are kind of like medical assistants on the ground with amazing resources and understanding of patients. And they really helped to take what we had taught everyone out into the community. When you're giving someone some assistance with, say, housing or food deserts and resources for food, that's a trusted relationship that then when they come into the office and we have the bridge COVID vaccinations available, we're much more likely to have success in getting people vaccinated. Next slide. So I'm just in the next couple slides going to show you some of our community resources that we tapped into. Prepare STL was an organization of our community partners who put together not only website information that anyone in the community could access, but also they had actual events out in the community that our community health workers would often go to as part of the larger network of all the different FQHCs and other entities. So you can see here on their website, they have lots of good links and pictures of folks that just are inviting. The next slide shows some frequently asked questions that they were able to post. So both in our office and our community health workers would often help patients learn about vaccination before they came in by directing them to these websites that helped dispel some myths and invite people to ask questions and engage. Next slide. And then as you can see here, they had lots of events, they had podcasts. In the slides that we received in our training around motivational interviewing and vaccination, on the left of this slide, you can see some of the resources that we gave all of our staff so that when patients who might be more comfortable asking someone at the front desk or a community health worker, that they could quickly help them know where to get the best information. Not that we couldn't give that to them at our health center, but we also wanted to spread the word from our patients to others in the community who might come to us to seek their care, whether or not they were insured. Next slide, please. So you can see on the left, that is our group of community health workers. A number of them are bilingual and very much understand the community. They have an office in our building, but they're rarely there because they're often driving around, meeting people, assisting with assessing social determinants of health and bringing resources that make a difference. You could see in the middle part of the slide, they had events where they had mobile vans where they were both doing COVID screening years back, but also bringing information about vaccination and just who we are as a community health center. Next slide. So these are our numbers, and I know this is kind of a, wow, it's a no-brainer. I'm going to walk you through this slide. We had bridge funding starting in October of 2023. We started vaccinating in 2022, but just as a comparison, if you look at all of 2023 from January through October, and then look after October when we started, not only because of the bridge funds, we used to give our COVID vaccination as separate clinics where someone would like see me for a visit and I'd say, why don't you make an appointment to go to our pharmacy and get a vaccine? Or, you know, why don't you, Missouri, as many states did, had a vaccinator finder. Why don't you look at your zip code and find all the places where you could go get a COVID vaccine, which would be available to you. So if you look at the first line, and I don't see if you can see my pointer, but this is prior to October. And these were the number of vaccinations that we were giving of our patients in clinic. And this was very limited because we didn't have the single dose and they were having to go to a clinic. And then after October, when we had the bridge funding, you can see for uninsured, that's a column bridge, it jumped up 8-fold the number of vaccinations that we've been able to give to patients from October until now. And then the insured jumped as well. We are one of those states that finally did Medicaid expansion. So it may look a little bit deceiving that our number of patients getting vaccination jumped more for insured, but that's in part where we could have had them coming to us uninsured. And then because of our outreach and enrollment navigators, help them get insurance. But I think word of mouth has meant that if you have a family member who's not been vaccinated, we want to take them on as a patient, whether or not they're insured, and they can get a vaccine just like you did when you came to an appointment, no matter what your health insurance status is. So again, this has been a huge win for us. We've been pleased to be able to have a number of patients roll up their sleeve and just be maybe 6-9 months ago, they were like, I don't want that vaccine. But now that we had it during a normal visit, able to get that vaccine, and they got it at the same time that maybe they got a flu shot and a pneumonia shot. So it's really lovely to have just a lot of people who might have been resistant turn and say, yeah, now that you have it, I trust you. I could have gone to Walgreens maybe, but I don't want to. I want it from you. So that is my presentation. And again, the message is when they're ready, if you give them the right conversation and you have access and their trust, they will receive it and they'll feel confident and not pushed to get it, but they're ready.
Thank you so much, Dr. Day. And that's really heartening to see your slide with the numbers. And so we've got, I know folks are really interested, especially I think when you were going through your motivational interviewing slides, and got a question or two about sharing the slides. The slides will be shared, everyone. So will the recordings. And we have actually done a couple other trainings on motivational interviewing that we'd be happy to attach to the same email that we'll send the materials from this session, just so you can get even more, because I think there's a lot of interest in that element, especially among the crowd that we have here. So thank you for sharing all of that. This is our time for Q&A. We have about 5 minutes left, and we only need maybe one to tell you about a couple things that are upcoming. So I know it's short, but we have some time for questions and answers. We're also going to launch a satisfaction poll. So if you all wouldn't mind, I think Zara's going to launch that for us. If you wouldn't mind answering that while you're also thinking about your questions. But I can get us started. So I'm curious, Dr. Day, do people know Bridge Access Program? I mean, are you finding that patients are coming with that in mind? They've been referred, they know the program by name, they know this kind of program exists, or are you finding that you're kind of capturing folks and they may not know it, but you're using the resources the bridge resources to vaccinate them?
To be honest, I think people are just coming to us because they want health care. And it used to be that sometimes if they were uninsured and they pay their nominal fee or copay, which gets them in the door, they're like maybe reluctant. I don't want a vaccine. Am I going to get charged for it? So I think it's really been huge for us to say, no, you've done all you need to do. We can give you anything that we feel that you need for your health. I don't know that anyone specifically asked for bridge access. They have said, do you have the COVID vaccine? And the lovely part for us is we can just grab from whichever is the appropriate, bucket of resources to be able to give it to them and not turn them away or not hand them a map or a website for them to seek it down. Because so many of my patients have said, even though I had convinced them that they wanted it, before we had it as a part of regular visits, they would say, oh yeah, I'll make time to go there. But then they come back to me and they haven't yet. And they're like so thrilled that they don't have to take off work or go to a website and find an appointment somewhere else, that they can just get it as a part of usual care.
Great, excellent. So I think Sarah is answering a question that's come in about how health centers can join the Bridge Access Program. So thanks, Sarah. We're going to do that one over chat. Jenny, a question came in for you about the uninsured demographic slide, whether we could review that again.
Sure. I don't know if we can pull it up again, but oh, thank you, Zara. I think it's slide 25, which if it just captures some uninsured rates for different groups. And the main takeaways that I see here are just the uninsurance rates for non-elderly adults are much higher than for children. And then you can see the large variation by race and ethnicity, with Hispanic and AIAN groups being the most likely to be uninsured. And then I didn't go through it when I first talked about it, but I showed the maps instead. But you can also see there that people who live in non-expansion states are about twice as likely as those in expansion states to be uninsured. So then when you get the slides, the next few are the ones that kind of look at the profile of the uninsured. And I hope, and feel free to reach out with any questions you might have about any of those resources. These are from KFF. And so they have a lot of good other data on their website about the uninsured.
Great, thank you, Jenny. And Jenny and I were also going to share, Jenny, I don't know if you already have, but we do have an email address handy that is a CDC email address that is focused on the Bridge program. So we have shared that before in other sessions that have been Bridge focused. So we can share that with you. I see, Sarah, that in your answer about how can health centers join the Bridge Access program, you have also shared your own email and have agreed that there are health centers who don't know about the program or that there are doses available to them. So could you chat that too, if you don't mind, Sarah? Could you chat your email? And we are actually almost at time, so we're going to Zara, would you mind moving us through to our very final slide? We do have a couple more things coming up in April that we want to let this community know about. So we do have a webinar next week on Thursday at 1. This is a collaboration with Culture One World, a learning community member, and the topic is activating social trends for vaccine uptake, lessons in social storytelling. And then we have a webinar the following week, our last one in April. That's Thursday, April 25th. This is a tentative date, but it's like 95%. We have not opened registration quite yet because we are just firming things up, but it will be that week. And this is the date that we think it's going to be. Just keep on the lookout if you're interested in this topic, which is winning new funding to sustain your health equity work. And I think all of us are interested in that. So that's also going to be a great session. And it will have a panel of learning community members, folks like yourselves who have tips on how to find funding sources and how to apply for new funding to sustain what you're doing under the PAVE program. So I'm actually going to, my final thing that I will do is that I'm going to chat the registration link and information for that first session, since that is open, and you all can head to it now if you are interested. So I will do that. And then we can close out the webinar. So I just want to say a big thank you to our speakers, Dr. Day, Sarah, Jenny. I know Ellie had to leave early, and to all of you. Thanks for sharing everything that you have with us today. And thank you to our audience for joining us. And we hope you have a great rest of your afternoon. Thanks so much.